Hello, I'm Dr. Mark Porter and thank you for downloading this edition of Inside Health. I hope you enjoy it. Hello and welcome to Inside Health. In today's programme, the Stoptober Stop Smoking campaign. The first mass quit attempt ever tried in the UK is now in its second week. But is it any more likely to encourage smokers to quit than past campaigns? Inside Health's resident sceptic, Dr. Cameron Abbasi, thinks it might. Medically unexplained symptoms. What doctors can do to help people with ailments that defy medical science.
By dinner time, my whole face had drooped. Called an ambulance and they took one look and said, you've had a stroke, we're taking you into the hospital.
But it turned out not to be a stroke, didn't it?
That's right.
Margaret McCartney reports, and epilepsy, why treatment with anticonvulsant drugs needn't be lifelong. But first, Nobel Prizes and stem cells. It's been announced this week that Cambridge biologist Sir John Gurdon will share this year's Nobel Prize for Medicine with a Japanese researcher for showing that mature specialised cells can be reprogrammed to become immature cells capable of developing into all tissues of the body. But what are the implications for the rest of us? What have the other stem cell researchers managed to build on Gurdon's foundations? Anthony Hollander is Professor of Tissue Engineering at the University of Bristol.
Well, building on the groundbreaking work of John Gurdon, of Professor Yamanaka and others, we're now in a position to use stem cells to create some tissues. In my lab, we are growing cartilage, and we were involved in growing an airway, a tracheal segment that was implanted in a patient in Spain, and we're running a clinical trial for knee cartilage as well. In other labs, there's work on the eye and on more complex organs such as the liver and the heart, although those are not yet in full use in the clinic.
Looking at your work, you say you're growing cartilage. When you're talking about growing a windpipe, you basically grew an artificial windpipe in the lab.
We grew a 6-centimetre segment of windpipe which has cartilage on the outside, at least that's how we put it together, and that was implanted in a lady who was dying because her airway was collapsing. Through the windpipe case, and a small number of patients since then who've been treated, not all of whom have survived, by the way, we know that we can do this kind of thing. We can use cells to create bits of tissue that will function well enough to save lives or modify disease, and that's great. What we don't yet know is whether we can scale this up to treat large numbers of patients relatively easily in a very controlled and safe way. We just don't have the information because we're still at that really early cottage industry stage, to be honest. There's not many groups who are really pushing into the clinic, although in California, where I sit on the grant review board there, they put large amounts of money into pushing these therapies into the clinic, but there's almost nothing that has gone through so far. So the UK is pretty far ahead, actually, in leading the way, and Pete Coffey at UCL is about to embark on an embryonic stem cell trial for macular degeneration.
So using the stem cells in that case, presumably to repair the retina at the back of the eye?
Exactly right, yeah. So, there are projects cooking up, but they all have their potential pitfalls because this is really new stuff, and just trying to do it safely and effectively is not straightforward.
And your work in cartilage of the knee, that's to treat damaged knees, presumably?
That's right. We would like to use this kind of tissue engineering and stem cells to either prevent osteoarthritis or to treat the disease in the early stages before it gets too widespread.
You say you'd like to. How far advanced are we along the pathway now? When might we see this sort of technology actually being used in patients?
Well, here in Bristol, we've just started a clinical trial using the patient's own bone marrow stem cells to repair torn knee cartilage, something called the meniscus, and that's underway in the earliest stages. Treating the other kind of cartilage, which you find at the ends of the bones, is a bigger challenge, and we're still a few years away from really doing that properly.
How good are we at the moment in controlling these stem cells in the lab to make them grow into what we want them to? It must be a very complex procedure.
Well, that's one of the biggest challenges right now. We know we can create these stem cells, and we know from Yamanaka's work that we can create them even from skin cells, but trying to get them to do exactly what you want them to do rather than go their own way and make lots of different kinds of cells is a fascinating scientific challenge and a difficult clinical one as well, because to be safe we have to really control that process effectively, and we're not there yet for most of these pathways.
And of course the problem being that if you transplant them into a patient in the form of cartilage and they carry on morphing into something else, that could be dangerous potentially.
Absolutely right. We have to stop them having this capacity for turning into lots of cells at the time we implant them. Otherwise, we're doing something potentially dangerous for the patient.
So on the one hand, you have to nurture them in the lab, but once they're in the patient, you have to stop them. How do you do that at the moment?
Well, it's about using specific growth factors, chemicals in the body which these cells can respond to, and using them in cocktails and at times which we find through discovery is best able to direct the cells in the way we want. So it's a lot of painstaking research to make that happen.
But we're making significant progress.
We are. Lots of labs around the world are doing really exciting work in these kinds of areas, and we're really at the earliest stages still, despite the fact that it's been a long time since John Gurdon's original work.
Another burgeoning field of medicine, and one that's also attracted its fair share of controversy, is the diagnosis and treatment of functional disorders. Although we often divide medical problems into physical and psychological, the distinction is an artificial one. There are few, if any, conditions that are truly physical, or all in the mind. Most are a bit of both. But even against this background, functional disorders remain hard to understand. They're a grey area. Physical symptoms like paralysis of an arm or leg with normal test results and no apparent cause, and where the patient isn't making them up. Margaret McCartney went to Edinburgh to learn more.
When it comes to disease, we humans find nothing more satisfying than being able to point a finger at the broken bone or throat infection that's making us ill. What we have trouble with is understanding how physical symptoms can be caused by the brain even when all the tests are normal. We feel somehow uncomfortable when the scan doesn't show a disease. We get the feeling we're not believed and it's all in our head. Yet the brain controls everything we do. If, for whatever reason, its messages don't get through, then it's really no surprise that our physical health can be affected. So why the stigma? Thankfully, there are doctors at Edinburgh's Western General Hospital who are trying to break down the barriers around functional symptoms and help people recover. Hi, you must be Alan.
Hi, Margaret.
Alan Carson is a neuropsychiatrist.
Functional symptoms are very common. In fact, they're one of the commonest complaints patients come to health services with internationally, and they've been long recognised really from the beginnings of written medicine. These were originally described as hysterical disorders, psychosomatic, or up until recently when I first got involved in the field, they were tended to be referred to as medically unexplained symptoms. But we feel this is a very unhelpful phrase because it obviously suggests they don't know what it is, whereas in fact these disorders seem to relate in some way to brain function and in some way also to psychological function, so they're at that sort of interface between neurology and psychiatry.
So what does having a functional disorder mean then? How is it different from any other kind of disorder or disease?
That sort of break the rules, as it were, of neurological disease. So in a paralysed leg, for instance, the reflexes might be normal, which we wouldn't ordinarily expect, and the presentation seems quite consistent from patient to patient. It seems to have roughly the same rate wherever you go in the world. Presentations are very similar, and although these are not at a level where we can use in an individual patient's diagnosis, we can see that there are abnormalities that govern the areas of the brain that plan and prepare for movement that are different from patients who are deliberately simulating symptoms.
So people are not making this up. These are genuine symptoms in genuine people who are not malingerers.
Absolutely. We're positively making the diagnosis of saying, I know what this is, as opposed to saying, God, I haven't a clue what that is, and saying, well, we'll call it functional then.
OK, Lucy, so can I ask you to just close your eyes as tight as you can and just keep them there, tightly closed, for about 10 seconds.
Dr. John Stone is an expert in functional disorders.
And are you feeling anything different in that right?
One of his patients is company director Lucy Bartley-Carr.
Basically, I'd woken up in the morning and I'd had a mild sensation of numbness in my face, but just assumed I was tired and didn't think anything of it. But by dinner time, my daughter, who's 10, had looked at it across and said, Mum, are you okay? Because my whole face had drooped on the right side, and then became aware that my right arm wasn't functioning either. And my husband, of course, panicked and called an ambulance, and they took one look and said, you've had a stroke, we're taking you into the hospital.
But it turned out not to be a stroke, didn't it?
That's right. All the tests, the MRI, CTs, bloods, everything came back normal.
That must have felt quite strange.
It was very scary in that, well, if it's not that, what is it and why? And it wasn't until I met with Dr. Stone and he'd done the few tests and had established what it was.
OK, so let's move on to the leg. Lucy, can I get you to lift up your left leg for me?
So can you explain to me what you're doing just now?
So From a neurological perspective, you make the diagnosis of functional limb weakness based really on the examination. So Lucy's got a very typical pattern of weakness with intermittency, and this is a neurological test called Hoover sign that really only occurs in patients with functional limb weakness. So what we're doing here is showing that when Lucy tries to keep her weak leg on the ground, so she's pushing down on the ground with her heel, she can't really do that. And then I'm going to ask Lucy to lift up her good leg and just really to stop me from pressing this leg down. Really stop me, that's good. That's nice and strong. Now, as she's doing that, I'm then going back to the weak leg, and I can find that the weak leg has become strong, and I can't now get the left heel off the ground.
So what does that mean?
What that shows me, and hopefully it shows Lucy as well, is that when her brain is distracted, the power comes back to normal. So the weakness can't be due to any damage in the nervous system. Instead, it's due to a problem in the way the nervous system's working and the messages going from the brain to the leg.
So you've described these as being functional symptoms. Is weakness the only kind of functional symptom you can get?
No, well, there's a whole range of functional symptoms in medicine generally. Weakness, movement disorders such as tremor or gait problems. Probably the commonest one are patients who black out and shake and really look as if they're having an epileptic attack. In fact, they're having what's called dissociative or non-epileptic attacks. And patients with functional symptoms in neurology very often have other problems such as fatigue and pain, memory and concentration symptoms, bowel symptoms, so it covers a very wide range of problems.
What about patients who say that there must be a physical reason, just doctors need to try harder with finding a solution?
I suppose in reply to that I would say that there is a physical basis for their symptoms because they're going on in the brain. It's just that the physical basis is a functional disturbance of the nervous system and the brain and the person rather than a structural disturbance. Patients do find that very frustrating that they can't see these things on scans, and then I would explain, well, there's lots of conditions you can't see on a scan, like migraine, irritable bowel syndrome. So it's really a case of just trying to explain to the patient why you've made that diagnosis, and it's not on the basis of that you think they're psychologically weak. It's about the physical symptoms.
But not everyone finds the diagnosis easy to accept.
It's quite common for patients to feel quite strongly that they must have a disease like MS or stroke. I have to say not all patients can be persuaded.
And it sounds as though that can be quite difficult sometimes if people have had bad experiences of doctors.
Yes, that's right. So some patients have seen doctors perhaps who are sympathetic but tend to come at the problem in a way that makes the patient think that they think they're imagining it. Other doctors really do think that patients are making these symptoms up.
While the causes of functional disorders are complex, there are some treatment options available, and I'm about to see some of them in action.
So let's give that a wee try again, Lucy. So if you bring that hand back down, so we want both hands working.
Alyssa Winters is Lucy's physiotherapist.
So at the moment she's working on trying to be able to pick something up and then, more importantly, letting go of it again. Now, as we let go...
That's part of the problem I've been finding with regaining the movement and the grip, because it is completely numb. There's no way of knowing if you've actually got hold of it or not. There's no feedback.
One of the things that we've been doing was introducing a lot of different sensory stimulus, so different things that would create feedback for the nerve. We were using hot and cold baths, sharp and soft objects, and over the last few weeks we've seen those approaches have a really good effect.
But, as Alan Carson explains, there's a place for psychological treatments too.
Although anyone can get it, it does seem to be more associated with people who've got other stressors on their system or who've recently had some form of physical stress, like an accident. So the rationales behind treatment are about trying to overcome that anxiety. So it's about breaking down sort of maladaptive patterns. But I liken it to my golf swing, which I would like to be perfect. But whatever I do to try and correct it seems to make the problem worse through nothing but desire to get better. And I think it's the same for patients in a whole area of medicine. And a lot of it's about just trying to unpick these patterns so that you optimise the natural rehabilitation process.
Well, it's been 5 months now, and I have to keep reminding myself of where I've been, because I was basically paralysed. And my speech was really bad. I do have bad days, but it's never as bad as it was. So I'm constantly making improvements. Learning to relax, learning to enjoy your time out. So, yeah, it's getting there.
Lucy Bartley-Carr talking to Dr. Margaret McCartney. And if you'd like to find out more about that approach to managing functional disorders, then you'll find a useful link on our website. Go to bbc.co.uk/radio4 and click on I for Inside Health. And if there's a confusing medical issue that you'd like us to look into, then please do get in touch. You can send a tweet, including the hashtag InsideHealth, or email me via insidehealth@bbc.co.uk. Debbie Williams emailed us to ask about the possibility of stopping her anticonvulsant medication, which she's been taking since she was 11, when she was diagnosed with grand mal epilepsy. That's the type where seizures result in loss of consciousness and shaking of the limbs. She writes, I haven't had a seizure since. I'm now 46 and would dearly love to come off my medication. What are the chances that I no longer have epilepsy? Consultant neurologist Dr. Brendan McLean runs an epilepsy service at the Royal Cornwall Hospital in Treliske.
The question that's being asked is extremely common, and in fact it's something I would consider when I'm putting a person on treatment in the first place, is when would we be making a decision about coming off? Because for a significant number of people it doesn't have to be a lifelong treatment. And what you're looking for is, can you tell when somebody first develops epilepsy whether it's one that might go away or whether it's something that's likely to trouble them on and off in their life. And there are some epilepsies, for example, particularly in children, which you know will disappear. So they only need treatment for a short period of time, and what you're doing is judging how long that period of time should be. There are others in whom you know from the description of the epilepsy it may be something that will be in their lives for a lot longer.
Our listener was diagnosed with grand mal epilepsy aged 11, has been seizure-free for 35 years. I mean, on that story, one would suspect the outlook would be pretty good if you were to come off medicine.
Oh yes, a very good chance. A lot of the childhood epilepsies disappear when you're grown up, and age of onset would be suggestive of one of those good epilepsy prognoses.
One of the interesting things here, as a GP, is that a lot of these people will be under GP's care rather than the care of a neurologist, and just on repeat prescriptions and often seeing different doctors.
It's better now, to be fair to GPs, because they have introduced an initiative which is reviewing people with epilepsy, and it's now done on their systems automatically. So hopefully people who are on treatment will get an annual review just to cover these very issues. There probably, some people might escape the system because if it was diagnosed that long ago, they may not even be registered as someone with epilepsy anymore.
Assuming somebody has good control, I'm talking about an adult rather than a child, so you don't know whether they're going to grow out of it in inverted commas or not. When would you start to consider withdrawing treatment then, if they've been seizure-free? Is there a certain period? Or?
In the old days, it often depended on the driving regulations, because remembering at one time, if you had a seizure, you lost your licence for 3 years. So people weren't terribly keen on coming off until they'd got their licences back when they were adults. And as the licensing regulations changed and that ban went from 3 years to 2 years, and now it's only 1 year, and in fact in some instances it may only be 6 months, the advice on how long to stay on treatment has to be a bit more evidence-based. And most people agree that 2 years free of seizures would be the time you'd start to think about bringing somebody off or having that discussion with them.
What are the disadvantages of coming off? I mean, obviously, the main one is that your seizure comes back.
That is the big disadvantage.
And the implications would be?
Well, seizures can be harmful to some people, injuries. A lot of it is more social. If you've got your driving licence back and you have another seizure, you lose your licence for 12 months again. If you're in a kind of public setting and it's important for you not to have something that's visible to others, that can be quite upsetting for people to know they're put into that position again. Young people, when they're leaving school and they're trying to set off in life and want to get their career sorted out, they might not want to take the risk of another seizure before they've established themselves in relationships or in jobs. So you have to have a discussion tailored to the individual.
And you can't look them in the eye as a consultant neurologist and say, look, the likelihood of seizures coming back are this. You just don't know.
You do have some rough figures. There's been a number of studies that have tried to look into how long before you take people off would it be relatively safe, and how many people relapse. And broadly speaking, about 30% of people may relapse, that is, have another seizure when you take them off treatment. can be higher depending on backgrounds. So you have that discussion to say, yep, there's a chance that you may have a relapse, but there's also a reasonable chance if you've been seizure-free for a period of time that you may have no further seizures.
What do we think's happening in these adults then that required treatment for their epilepsy, their seizures? And 2 years later, they've not had any seizures. What's changed in their brain? Does the medicine change the brain? Do we understand why the seizures don't come back?
That's, again, a kind of research question. If you look at societies where they can't afford anti-epilepsy drugs, and that's many parts of the world, they have these natural fluctuations in seizure control without treatment. So some people will go through spells of seizures, then many years with nothing, and we've not altered anything in their lives. So I think the brain has a capacity to try and suppress seizure activity itself, but it's vulnerable to breakthroughs, and external influences might cause problems. Alcohol in this country is a big issue. Alcohol is one of the commonest causes of admission to hospital with a seizure. So there are other external factors, but in some people it's just, in some ways, luck, whether it comes back or not. In others, you can get a better idea. If, for example, you've had a brain injury, so if you had a car accident, trauma to the brain and got a seizure, you've got a scar, and that scar is more than likely to trigger more seizures when you come off treatment. So people who've had brain injuries of all descriptions are less likely to come off treatment and remain seizure-free.
What are the main benefits to the patients of coming off treatment? What do they notice?
When you've been on treatment for a long time, you might not notice that anything until you come off. And I've had a few patients who said when they've been on some of the older drugs, after 30 years when they came off, they said they felt as if a veil had been lifted from them. They'd been living their lives in a kind of a slight cloudiness. But because they'd lived their lives like that, they never knew any different. So some people will notice coming off treatment an increase in alertness. A lot of anti-epilepsy drugs are completely safe and free from side effects, but some people are sensitive to them. Psychologically as well, to take a tablet every day reminds you of something. And freedom from taking medication can be liberating for some people.
Dr. Brendan McLean talking to me in Cornwall. We're now in the second week of the Stoptober campaign, a mass quit initiative in England to try and encourage smokers to give up for at least 28 days, complete with support pack, phone app and daily motivational text. It's the latest in a long line of stop smoking campaigns, but the most ambitious so far. But is Stoptober going to prove any more successful than its predecessors? Dr. Cameron Abbasi has been looking at the evidence.
Yes, it's easy to be cynical about these types of campaigns, but in terms of stopping smoking, there are two potential reasons why it may be beneficial. Number one is that the research data shows us that there may be many people, in fact the majority of people, smokers, want to give up. Now, what signals your intent to give up is very much setting a date, to say on this day I will give up. And a very small proportion of the people who want to give up end up making a serious attempt. So Stoptober, firstly, is giving people an opportunity to say on this date I will stop smoking, and I intend to stop smoking for as much of the month as possible and hopefully beyond. Secondly, the research evidence shows us that the group behavioural therapies tend to be much more successful than individual counselling. So if we take Stoptober as an extreme of that, there may be thousands of people giving up together. There's the power of groups, the power of groupthink. That's another rationale to suggest that potentially peer pressure from other smokers who have given up this month, your family, and just hearing much more about it in the news may help you stay off cigarettes.
And the guilt of standing outside that office block in October with everybody knowing it's Stoptober and you're supposed to be not smoking.
Yes.
The other thing that interests me, as a clinician at the coalface, is that I often see willpower as being an important part. We often forget about it. It's a very difficult thing to measure in trials. But patients who want to stop for a valid reason often do it surprisingly successfully.
Yes, there is some evidence that willpower, as you describe it, can be the most important factor. And
so these are patients who feel they want to give up. They're not doing it because they're being told to or pressurised into it.
Yes, precisely. And also there's some evidence that if you give up and stop smoking without any assistance in terms of drug therapies that might help you or counselling that might help you, if you successfully give up, you're more likely to stay off cigarettes than people who've been helped with other therapies.
The problem is you're less likely to succeed in the first place,
yes,
so it's
true.
a bit of a catch-22.
Yeah.
OK, Dr. Cameron Abbasi, thank you very much.
The Prime Minister will host a summit of insurance, consumer and business groups at Downing Street later today to discuss ways of bringing down the rising cost of premiums, particularly for motorists.
Whiplash is an issue that's been in and out of the news ever since Inside Health first aired at the beginning of the year, amid calls to stem a burgeoning compensation culture that's costing British motorists around £2 billion a year. Dr Trish Groves is Deputy Editor of the British Medical Journal and has been following developments closely.
Well, we reported back in January, so January of this year, that there was an increasing problem with the number of whiplash claims, so much so, actually, that the House of Commons Transport Committee said that the UK was now the whiplash capital of Europe. This was because the claims after car crashes, financial claims, had gone up to about 550,000.
Individual claims?
Yeah, during 2010 to 11. And this had driven up motor insurance premiums by up to 70%. But if for your average claim for some, kind of safe middle-aged driver, that meant an extra 90 quid on your annual insurance premium, which is quite a lot.
What's the official definition?
Right, well, the official definition is that it's an injury to the neck caused by the head being thrown forward and then backwards. So in a car crash, that would be because you've been shunted from the back or really hard from the side sometimes. Basically, it's a sprain of the ligaments in the neck. But there's even more of a problem that GPs actually aren't sure how to diagnose whiplash or what it is. And when you go and try and dig around for evidence on what whiplash really is and how to treat it, you don't find much. Normally it's very mild and it goes away in a few days. And that's that. You can take a bit of paracetamol and it's gone. The problem is that if somebody rings you up after you've had an accident and says, have you got a sore neck? And you go, well, it's a bit sore. And you go, oh dear, well, that can be very nasty. It can go on for months. We could probably get you quite a lot of money for that. All you have to do is go and see your doctor. An awful lot of people aren't going to refuse that. If they go to their doctor, there's nothing much you can do. You can't do tests because even if you do something like a magnetic resonance imaging scan, what's it going to show? It might show a little bit of sort of swelling or something a bit funny, but that has been shown in research not to relate at all to whether people have got a sore neck or not. So in the end, you're left with the patient's symptoms. Now, if that patient has arrived being told you've got something wrong with you, it might go on for months, you're probably going to, have a nasty time and have time off work, you better have some money. What's the doctor got to do? And this is with only, a few minutes per patient in the surgery.
There's a school of thought amongst many clinicians that it's the term whiplash because it's very evocative. That maybe we should be talking, as you talked about there, a sprain of the neck, and perhaps that wouldn't create such a...
Yes, it really is dramatic, isn't it?
It's often seen as a victimless crime, isn't it? I mean, why wouldn't you claim if you can get £1,000 or £2,000 just by going through a few basic measures? But actually, we all end up paying for it.
Well, yes, actually, and sometimes patients do, because there is research showing that people who feel that their whiplash isn't getting better over a long period, often that's associated with anxiety and depression. And of course, you're not quite sure which has come first, the feeling low or the symptoms, and they all get muddled up together.
Waters that can only be muddied further by the compensation culture. Trish Groves, thank you very much. Just time to tell you about next week when I'll be finding out about the most common form of tremor and why some people get the shakes. And we meet a team of doctors and nurses who've come up with their own alternative to the dreaded hospital gown, medical pyjamas. You've been listening to a downloaded edition of Inside Health. If you'd like to hear more, please visit the Inside Health website at bbc.co.uk/Radio4.